Welcome, everyone. Thank you so much for joining us today. I'm Susan Boas, the Executive Director of the PANDAS Physician Network. At PPN, our vision is that PANS and PANDAS will become easily diagnosed and treated with accessible therapies that dramatically reduce suffering and lead to a cure. I'm so pleased to introduce Dr. Amy Young. Dr. Young is the founder and clinical director of the CBT Center for Anxiety and OCD, and has been working in the behavioral health field for nearly 30 years. She holds a clinical psychology doctoral and a master's degree from the Philadelphia College of Osteopathic Medicine, a doctoral program specializing in cognitive behavioral therapy. She's worked at Children's Hospital of Philadelphia and Connecticut Children's Medical Center. Today, Dr. Young will discuss the essential role of psychologists in supporting families affected by PANDAS and PANS. At PPN, we recognize that psychologists offer critical assistance in three key areas. The first is in supporting the diagnostic process. Psychologists are a vital role in helping families and healthcare providers distinguish PANDAS and PANS from other psychiatric disorders, such as traditional OCD. Many pediatricians report to us that psychologists provide them the confidence needed to recognize the unique onset of PANDAS and PANS, which aids in accurate diagnosis. The second is in the search for medical care. Psychologists are a valuable bridge in the medical journey, guiding families through the often difficult and complicated process of seeking specialized medical care for their children and providing documentation and evaluations as needed. Beyond the steps of diagnosis and care navigation, psychologists also offer essential mental health support to both patients and their families, addressing trauma, OCD symptoms, and other psychological challenges associated with PANDAS and PANS. We're excited to learn from Dr. Young how psychologists and pediatricians can collaborate more effectively to support these families. You can post presentation questions via the chat function, and at the very end of the presentation, we will have a Q&A before the end of the session. Thank you so much for joining us, Dr. Young. I'll turn it over to you.
Thank you. I appreciate that. I'm going to share my screen. Wonderful. Hopefully everybody can see that okay. I'm just going to slide this on over. So I want to thank everyone who is in attendance and welcome you. I appreciate your interest in the topic and your interest in helping children and families who are impacted by PANS and PANDAS. The role that psychologists can play in helping these families is nothing short of profound. It is, for those of you who work with this condition, an incredibly complex, complicated condition, both medically, socially, psychologically, financially, that impacts the child as well as the family. So the role that the psychologist can play in supporting these families is pretty profound. I have a number of slides here today, and in some ways, too much information to cover over the period of an hour, but I will do my best to touch on a lot of the issues here in the presentation. So for starters, some of the common experiences that families may have when having a child who is diagnosed or is suspected of being diagnosed with PANS and PANDAS. And I'm just going to highlight some of these, and just to give by way of background, as Susan said, I'm an anxiety and OCD specialist, have been working in the field for 30 years and have been working with kids and their families with PANS and PANDAS for probably about 20 years or so. And what we find with this condition are a number of things, including caregiver burden being incredibly high. The task that parents have with regards to parenting and finding treatment and accurate diagnosis is incredibly high. It often is an uncharted treatment path, one that they're often trying to figure out on their own, trying to put the pieces together by themselves, needing to rely on a lot of investigation. It's not uncommon that I'll hear from families that they're up late at night trying to find answers for their child. So oftentimes it's unassisted and uncharted territory. Unfortunately, as many of you know, many medical and mental health professionals are unaware of PANS and PANDAS. And again, that's why I extend a sense of appreciation for everyone who's in attendance of this. The more people that we can make aware of this condition, which oftentimes has significantly higher prevalence rates than the average person might suspect, that it is incredibly helpful to have as many people as possible aware of the condition. And unfortunately, a lot of families run into having to educate their provider, their pediatrician, and potentially even a therapist about these conditions. The burden includes many doctors and specialist appointments, and you can imagine what can come as a result of that. It can be expensive, time-consuming, exhausting to tell your story over and over again. It can be traumatic and very difficult to say the least. Other common experiences may be parents having to take leave of work on family medical leave, disruptions in work schedule, just having a lot of difficulty maintaining that work-life balance because the needs are so great for these children. Their child may be at home due to emotional dysregulation, depression, irritability, outbursts, separation anxiety, difficulties eating, just to name a few. There can be separation anxiety. Parents can experience sleep disruption. Sleep disruption because their child may have difficulty falling asleep or staying asleep, and also sleep disruption because of the worry that they experience or the burden placed on them trying to figure this out for their child. There can be symptoms that are very difficult to manage: behavioral dyscontrol, irritability, aggression, depression, self-injury that can make life very difficult. There can be social isolation that parents experience, unfortunately, very commonly. Social isolation because the people around them may not believe their experience, that they may have well-intentioned extended family that may give them unsolicited suggestions of just being more disciplined with their child, going too easy on their child, not wanting to share this information based on some of the symptoms that the child may be experiencing, and just really not wanting to share what they're going through with other families. The rest of the family, as a result, may feel neglected. So this really has a significant ripple effect into the entire family. Spouses, partners may feel neglected with the lack of emotional reciprocity, the ability to be present and attend, to physically interact, to be physically intimate, to spend time with other members of the family. It could just be incredibly exhausting. The social support system may break down, or again, as I said before, they may find that the social system is critical. Why don't you just discipline your child more? You're letting them get away with this. And again, they may not feel comfortable to share about that. Sometimes we may even see families split up, that they find that given the disruptive behaviors that can come along, sometimes with the symptom picture of PANS and PANDAS, that at times being in separate places or even having separate homes may be helpful or necessary, or sometimes a parent seeking really specialized treatment in a state that's miles and miles away from their home and having to get a hotel or an extended apartment in order to access that care. And this is really just the tip of the iceberg in many ways in terms of common experiences for families with children with PANS and PANDAS. The list could really go on. So part of the role that psychologists and therapists can play is in educating families. That the role that therapists can play is really multifactorial. And again, I can't say enough about the importance of having a psychologist who is well-versed in these conditions, how helpful that can be. So psychologists can work to educate families about PANS and PANDAS. They can help in the diagnosis. As Susan said, they can help them navigate treatment waters, some of the medical, make medical recommendations, how to find a medical provider. They can also support the family by being a listening ear, going over some of the unfortunate normal components of having a child diagnosed with PANS and PANDAS. So psychologists provide a lot of education. Psychologists can offer family support groups, both for the child with PANS and PANDAS, whether it is a specific PANS and PANDAS support group or whether it might be something more specific to some of the manifestations of PANS and PANDAS, that being OCD or RFID or difficulty separating. Support groups for families are areas that psychologists can help with. Psychologists can also help educate in being knowledgeable about the medical care. One thing that I really like to stress when I'm training some of our clinicians on this topic is that the psychologist or therapist is not expected to know absolutely everything that there is to know about the medical care. We do our best to stay apprised of what treatment looks like, but the treatment terrain is forever changing. And so we do our best with that. And it's also a little bit of a tricky situation that therapists may find themselves in, is that it's not uncommon with these conditions that as parents educate themselves on treatment options, that sometimes parents may know more about medical options than even the clinician does. And that can be a bit of an odd spot for a therapist to be in, and to know that that's okay. To be in that position where at times the parent may know a bit more about the medical piece of the side of things, and to not let that to deter you as a therapist, to really set your ego aside and to do what we can to keep up and to learn, but to let that be okay. We can educate families in terms of the particular assessment that's recommended, the lab workup. We can educate families on advocating for that and really pushing, even if the first physician says no, to continue to ask and be assertive, providing sometimes families with particular resources that they can go into seeing their medical professional with to help legitimize some of their concerns. We can educate families in terms of what to do in a crisis, how to provide de-escalation, where to go, what are the inpatient facilities, what level of care the child may benefit from in a crisis, and can also make recommendations in terms of crisis, which facilities may be more PANS and PANDAS friendly, and pointing them in that direction so that they're set up for success. Psychologists can provide families with information, again, in terms of diagnosis. We can also help in terms of shaping the treatment plan. We can help in triaging the symptom problems. So one of the things about being a therapist is that we are able at times to see things more holistically, to see the psychological, the medical, the social, the financial, the emotional side of things, and really helping the family move in a direction that provides the greatest quality of life for the child and for the family, and really being able to contemplate those things. I had a family recently that was recommended a lot of pretty intense treatment for their child's condition. And as a result of the condition, both parents had not left the house together for some period of time. It had been a couple of months since they had left together to just spend time together as a couple. And so my recommendation, given that they were about 3 months into this situation, was that there was a point of diminishing returns for them to stay home with their child 24/7, that at some point that it was really important for them to leave the house and have time together as a couple, because there can be this point of diminishing return and loss of quality of life. And if parents aren't doing well, then kids aren't doing well. So we can see the big picture of things, see things systemically, and make appropriate recommendations. We can, again, support families by making recommendations for various support groups. We can provide a safe, non-judgmental place to talk, to normalize things, to validate their concern, that when they share with us that they shared with their in-laws what was going on, and their in-laws said, you just need to be tougher, on your child, you're being too soft, that we can provide a safe, non-judgmental space to normalize, to be informed about the condition, and to let them know that unfortunately things like that can happen. So it can be a place that families feel really heard, to not be made to feel like they're crazy, like they don't know what they're doing, that they've got it all wrong. We can be a place to support families, to encourage them to trust themselves and to know that they know their child best, and that they're not making it up, and that the condition is not due to poor parenting. We can facilitate treatment. We'll go into some of this a little bit more in some of the later slides. Certainly can facilitate treatment along the lines of some of the typical things that we do, including cognitive behavioral therapy and specifically things like exposure and response prevention, or ERP, as the symptoms warrant. And we'll go into that in a little more detail in some other slides. Psychologists can also play a role in terms of a consultation model and collaborating with other professionals. So, psychologists and therapists have the capacity to collaborate with other professionals, such as physicians, immunologists, psychiatrists. We can work with school psychologists, guidance counselors, teachers, to really make sure that the child is getting the best support, that they're most set up for success, because PANS and PANDAS occurs across settings, and to make sure that everybody is as informed as possible. We can work alongside pediatricians, giving them feedback. We can work alongside psychiatrists to let them know if the medication regimen that they have recommended is helpful. Work alongside neurologists and other specialists to provide, again, a more holistic view. And this collaboration is vital in terms of getting the most positive and robust outcome. Psychologists can assist in conducting evaluations and beginning to differentiate between PANS and PANDAS, or other psychiatric or developmental disorders. It certainly helps for the therapist who has worked with a variety of conditions and can feel more confident in the differential diagnosis. Um, the psychologist and therapist can help in gathering the history. The therapist can help in observing behavioral patterns, seeing things in the session. How does the child behave? How do they respond? What does their body look like? Do we notice any movements? What's their emotional regulation like? Are their pupils dilated? How do they respond in a number of situations? We certainly can utilize standard assessments. We can identify specific symptoms, obsessive compulsive behaviors, anxiety, behavioral changes, regression, tics, mood changes, and being able to assess and document and share in consultation with the family, with other health providers. Psychologists can also assist in getting family input, helping them in the assessment process to really get a full picture of the child's functioning and the impact on family dynamics. So, therapists at times have a little bit more luxury of time, although sometimes our time feels so short that, in comparison to other medical providers who may have 7 to 15 minutes with a family, we may have 45 to 60 minutes or longer, being able to really get a full picture of what's going on and a full picture of the impact on the family. We can monitor progress, track changes in symptoms over time to really help refine that diagnosis and inform those treatment decisions. So, unfortunately, sometimes what we see in research is not always what we see in clinical practice. And that's really where the artful clinician comes in to be able to really assess the situation, to eyeball it, and to be able to point the family in the correct direction. We can also assist with documentation and reporting, providing summary findings, diagnoses, recommendations for treatment to share with the family and other healthcare providers. Certainly, therapists can provide evidence-based therapy. So this is a big part of often what we think about when we think about the ways in which we can assist with families. Um, so providing cognitive behavioral therapy, evidence-based therapies, and specifically to treat some of the symptoms, whether it's anxiety, compulsive behaviors, tics, separation anxiety, behavioral regression, separation anxiety, trauma, behavioral discontrol, emotional distress. All of these things the therapist can assist with. And there's evidence-based practices for each of these symptoms. We can also assist families in adjusting to the new norms. Unfortunately, with these conditions, they take time. These are not sprints, these are definitely marathons. And part of the role that the therapist can play is in assisting the family in their own adjustment. So it's not uncommon that for families, and this can be for caretakers as well as siblings, there can be times where they're experiencing even adjustment disorders or their own trauma related to the condition and what's happened to their sibling or to their child. whether it is not being believed, or the length of time that it takes to get a proper diagnosis, or whether it is dealing with the separation in family, or the lack of sleep, or the confusion and the frustration, or the exhaustion that can come from having to navigate even the treatments for these conditions. So really supporting the entire family. It's not uncommon that when we're working with a child with PANS and PANDAS, that some of the work that we're doing is not just individual work with the child, but we're also really taking a systemic approach in working with the entire family. It's not uncommon that I work with siblings, have entire families in, which would not typically be the way that I would operate if something was any of these conditions or symptoms that were not related to PANS or PANDAS. So if I had a child who had separation anxiety not related to PANS and PANDAS, it wouldn't necessarily be that I would have, the whole family in, or the siblings. But when it comes to separation anxiety that occurs as a result of PANS and PANDAS, it may be really appropriate for me to have the entire family in, including siblings, because there's just such a tremendous ripple effect across the whole family system with these conditions. So when we're using these specific therapeutic interventions, we're really tailoring them to address the unique needs of each child. And, these techniques obviously are there to enhance their coping, their emotional regulation. So we're applying specific evidence-based strategies for any one of the sequelae of PANS and PANDAS, but we may also need to tweak them based on some of the typical characteristics of PANS and PANDAS. The fact that a child may be experiencing a flare, for example. So the treatment may not be quite as streamlined. The slope of the line may not be as clean. There can be a lot of 2 steps forward and 1 step back, or a couple steps forward and a couple steps back. And that can be incredibly normal. So really staying the course with the family and really encouraging them to understand that if there are some steps back, that it is not indicative of the overall prognosis, that it's expected as part of the course of treatment, and really towing the line and holding the hope for the family, holding that safe space for them, and continuing to persevere through that. So many of the treatment protocols that we have for these specific sequelae, they may not really do it entire justice, and that they're just much more complicated. So we utilize a lot of the evidence-based treatment protocols as kind of a backbone or a template to guide what we're doing as therapists, but also holding it lightly, being able to meet the family where they're at, knowing that at times we may need to pump the brakes, we may need to switch gears, we may need to pause, we may not need to add in some additional strategies that we wouldn't otherwise. That can be quite normal, and again, the role of the therapist. So again, our job is to observe the client in different settings. So therapists may go to the child's home. They may go to the child's school. That would be something as exposure-based therapists that wouldn't be entirely uncommon. But if we're also working with some of the sequelae as a result of PANS and PANDAS, that may be especially helpful to go to the child's home or their school, one, to collect data and to provide some observational information, but also to be able to implement some of the treatment within the child's natural system. And that can help with the generalizability that might be beneficial, that might not be necessary with a non-PANS and PANDAS diagnosis. So there can be some learning differences in the way that the child and family take in the information. Our role, again, could be to do a differential diagnosis to really ascertain, are we talking about PANS and PANDAS etiology? Are we talking about some other psychiatric or neurological etiology? Really trying to work to get an accurate diagnosis, which again can take time. We've talked about collaboration. So some of the kinds of specific evidence-based practice that a therapist may employ when working with these families can include things that fall under the auspices of cognitive behavioral therapy, which is really just a broad brushstroke term, and it encompasses a number of specific kinds of cognitive behavioral therapy. So to some extent, depending on the specific presentation, the specific difficulties that the child is having, of which can be many, we would apply evidence-based strategies for that specific sequelae. So for example, if someone is experiencing obsessions and compulsions, and is meeting diagnostic criteria or having symptoms of OCD, then we may use exposure and response prevention. Parent coaching may be a role that is incredibly helpful for the therapist to utilize. And I would say that is one of the ways that working with some of these symptoms, when it is a PANS and PANDAS diagnosis, that can be a little bit different in that I would tend to use a bit more parent coaching with these conditions than if it was just pure separation anxiety or pure OCD, or some other kind of behavioral issue. I tend to use a lot of parent coaching when it comes to a PANS and PANDAS etiology. We might use parent-child interaction therapy for some behavioral discontrol, some irritability, some disruptive behaviors. We might use what's called a space model to reduce family accommodation. We might use some concepts from acceptance and commitment therapy. Now, some of those concepts tend to be in some ways a little bit more metacognitive, so it would be really important that the skilled clinician use those in such a way we call that is flexible within fidelity, where we're using the concepts, the backbone, but really presenting them in a way that is appropriate for the child and appropriate for the family. We might use some DBT strategies like grounding or five senses or a tip strategy. We might use some mindfulness exercises, various kinds of affect regulation strategies, including progressive muscle relaxation, diaphragmatic breathing, autogenic training, guided imagery, all kinds of affect regulation strategies. We might use behavioral activation if there's a lot of depression going on, really trying to pursue a greater sense of mastery and pleasure. We may use things like attentional training. So some of the specific evidence-based practice strategies that we use will depend a bit, again, on the presentation. What are the specific symptoms that are most profoundly presenting in the PANS and PANDAS presentation? So again, the role of the therapist is to support families, offer counseling, support. And again, I would say that if I was working with a child who had separation anxiety or tics or some kind of behavioral regression or OCD, I certainly would want to include the family as a matter of course. But when I'm working with a child with a PANS and PANDAS etiology, I definitely want to be that much more cognizant. It's not uncommon in these, when working with these families, that I'm, if time and finances permit, that I am offering at times even multiple sessions throughout the week. So I may have a session with the child, with the parents coming in and out of the session as appropriate, maybe at the beginning and the end. And then I might do a separate session for the family, for the parents, for maybe the primary caretaker. And in a couple of ways. One, in a place to give them some guidance in terms of additional resources. Two, to maybe walk them through removing accommodation or implementation of specific cognitive behavioral therapy strategies. And three, really to offer a non-judgmental, safe space for them to share about their experience, to emote, to cry, to feel loved and cared for and validated and normalized, that can be an especially important component of the role of therapist, and just helping them navigate the emotional toll in whatever way, is appropriate. So with these cases, it's not uncommon for me to also utilize family therapy where we're bringing in multiple members of the family, and that would be something that's different than the way that I might operate in a non-PANS and PANDAS etiology. Promoting healthy communication, understanding within the family unit. When we're doing family sessions, having siblings speak up about what their experience is like. It might even be, although somewhat uncommon, but it might even be that I have a session with a sibling, just with a sibling, to talk about their experience and what it's been like for them and how they feel and what's happened within their family and any trauma they've incurred or sadness or loneliness or disconnection that they're experiencing, and really promoting open communication with regards to that, and really just addressing family dynamics and communication. So if it is a family that already struggled with some of those dynamics and communication, PANS and PANDAS is definitely going to make it that much more complicated. Various support groups, again, that the therapist can facilitate or recommend, that can be incredibly helpful in normalizing just a place to talk about one's experience. Um, we've talked about some of these strategies. So again, depending on the specific symptoms that are presenting, there's a variety of evidence-based practices that we can utilize. So, for example, if the presentation involves a lot of OCD symptoms, then we would use evidence-based practice, various cognitive behavioral therapy strategies, primarily exposure and response prevention, to work on reducing compulsive behaviors and really working toward, depending on what exposure model we rely on most, creating a habituation or potent inhibitory learning. We might employ some metacognitive treatments to really get at some of the meta layers, some of the vulnerable self models, some cognitive diffusion, and that's sort of a whole, some of these topics are a whole training in and of itself. If anxiety was the primary presenting difficulty, we would use specific techniques to use some cognitive therapy, maybe go through some classic psychoeducation around different cognitive distortions, maybe teaching the client some basics on cognitive diffusion or cognitive disputation, giving skills in terms of affect regulation or distress tolerance, or choosing more value-oriented choices. We might teach some mindfulness-based stress reduction. Again, I could, give a whole presentation on each of these slides. A therapist can assist with some of the behavioral issues, that being aggression or irritability, looking at various kinds of mindset, looking at different emotional regulation strategies, various behavioral strategies, some kind of token economy or positive reinforcement to modify those behaviors. And again, perhaps some parent-child interaction therapy, some parent management training, really educating parents on ways to get a more successful outcome. And none of these things is, I have a little, I'm looking at some of the misspellings in there. So as a person who specializes in perfectionism, it always makes me smile when I see some grammatical error or misspelling, because we try to live the exposure lifestyle and do what we encourage our clients to do. So, we're really working within the specific presenting problems and providing evidence-based practice for that, but also holding at the same time that the course may be very rocky, that we may need to take pauses, that we may need to modify the procedure, that we're not looking to in some kind of robotic way and overly manualized way, provide a protocol, because it's just not going to work. So it really requires that the therapist is open-minded, non-judgmental, and incredibly flexible, because which is a positive attribute of a therapist anyway, but particularly in these situations, it can be important to be flexible. Because the therapist may have a plan that day, what they thought would be useful, maybe building the exposure hierarchy, for example, or teaching some distress tolerance skills. And the family comes in with a very different agenda. Maybe something has happened, or they just need different skills that day. So it can be really important for the therapist to be able to think on their feet and to be able to switch gears and really meet the client where they're at on any given day. Really working to hold the overt progress lightly can be incredibly helpful. So as long as the therapist knows the North Star direction that they're going in, which I believe our overarching North Star direction is to help people have a life worth living, is to help improve the quality of life of those around us, that there's lots of ways to do that, that it doesn't have to be a set way. And the therapist's job is to see the big picture. And that becomes a little bit easier, obviously, the more individuals and families that you work with, that you're able to see your way through the maze and to help the families through that maze, and is to hold the hope and the big picture through that. The therapist's job can also be to assist with crisis, providing immediate support. It may be a situation even for therapists who prefer to be quite boundaried with their time and maybe boundaried about rules about communication through texts and phone calls and emails, where I encourage the therapist to consider the possibility to be a little bit more flexible with these families. They're going through a lot, and it may be that they would benefit every once in a while from some support or coaching outside of office hours and being flexible with that. So, being able to provide some immediate support, knowing again where to recommend that they go if they're in crisis, which places are PANS and PANS friendly, suggesting some strategies during acute episodes or crises to really ensure that they have the resources, that they need. Um, and sometimes this can get a little bit tricky. So I always like to I tell my staff I like to keep it real. So for example, there may be some things that you as a psychologist are aware of that can assist the family, maybe like the use of over-the-counter anti-inflammatories like Motrin or Advil, that really as a therapist, we're taught to stay in our lane and that we're not medical practitioners and that it's really important that we don't give medical advice. And at the same time, we may be aware of a solution that could potentially help both maybe with diagnosis as well as immediate intervention that a client reaches out to us on a Friday evening or a Saturday. So if I give those kinds of recommendations, I try to provide them with caveats that the family understands that I'm not a medical provider. And so when I give any kind of potentially medical advice, that I want them to understand my role as a psychologist and that I didn't go to medical school, and nonetheless, I would not want to withhold important information if there was something medically that I might suggest that they do that could really help them in a pinch, give them some immediate relief, and encouraging them certainly to reach out to their medical team, their provider, their physician to get concurrence with my recommendation. We may suggest de-escalation strategies. There may be children, for example, who benefit from certain temperatures or sensory experiences, from the use of water or heavy blankets or various tip strategies or grounding strategies, moving their body, things like that, that can certainly help, and basically ways to turn down the volume on the fight and flight. There can be strategies that therapists can recommend in terms of irritability and mood swings and depression and mood disturbance, specific cognitive behavioral strategies, various recommendations along the lines of behavioral activation in terms of activity scheduling. And again, each one of these specific slides on interventions for symptoms could be a talk in and of itself. So I can appreciate that I'm really skimming the surface with this. And I'm doing it in an attempt to try to cover the bigger picture with this. We can offer some specific strategies in terms of any self-injurious behaviors that might occur, various DBT strategies that we can be well versed in. Again, various grounding, five senses, tip strategy, the use of ice, various HRT, habit replacement strategies, ways to cope ahead, opposite emotion, distraction. So DBT in and of itself is an incredibly comprehensive evidence-based practice, which many of the workbooks are hundreds of pages with hundreds of strategies. So just really too vast to cover in a slide, but suffice it to say that there are various DBT strategies that could prove to be very helpful. And again, this is the role of the therapist to suggest these, to experiment with them. I like to remind clinicians that David Burns is quoted in saying he's a cognitive behavioral therapist, that when therapists recommend strategies, there may be 9 out of 10 that aren't effective, that don't help, and that there may be one that is. And to really normalize that for us as therapists, when I'm making specific recommendations, that I go into it full well knowing that there may be many recommendations that I make in my toolbox, which is vast, that may not be helpful. And we're here to collaborate. We're here to find the things that work for your child so that you can develop a toolbox that is useful. There's also, in terms of self-injury, there's the Cornell self-injury research that I'd like to let people know about, where they have a number of resources on there in particular with regards to self-injury, and lots of handouts and strategies and really useful psychoeducational materials. Therapists may also assist in a variety of symptoms, hallucinations and delusions, by way of stress management, social support, family support, certainly encouraging medication management and adherence to medication management. Therapists can assist with sleep disturbance, whether it's sleep hygiene protocols with a bedtime routine, a warm bath or shower, like carbohydrate snacks, minimizing screens, the same bedtime each night. Again, I could talk for an hour about sleep hygiene, and various cognitive behavioral therapy for insomnia. There are specific protocols for that as well. We can assist with cognitive impairments, various recommendations on executive functioning strategies, modifying. We can, recommend and advocate for 504 accommodations, where the child is able to show mastery instead of having to show completion for homework, extended test time, extended assignment time, visual reminders, quiet places to study, tutoring. Again, we can advocate for educational supports like a 504 and IEP. We can assist with management of tics through cognitive behavioral intervention for tics. Again, I could spend a whole hour on evidence-based practice for this. And that's just a little bit about what CBIT looks like. We can assist with social withdrawal through social training, ERP, group therapy. And certainly there's a place for the therapist in terms of the trauma that clients and families will experience. Long ago, in a far off distant planet, there was a time in my life as a clinician that I worked at Children's Hospital of Philadelphia, and I worked as a research assistant in their psychology department, working on a study for families newly diagnosed with a child newly diagnosed with cancer, and really assisting with some of the research in the post-traumatic stress symptoms that families experienced when they had a child newly diagnosed with cancer. And as I began to work with these families, I came to realize that having a child diagnosed with PANS and PANDAS is not in any way dissimilar, and in fact, arguably more complicated than a family who has a child newly diagnosed with cancer, because and in no way to minimize the experience of having a child with cancer, but oftentimes the parents of the family of this child with cancer do not have to navigate finding treatment. They don't have to navigate being told that they're just not being disciplined enough with their child. They don't have to navigate being told that their child has conversion disorder. They don't have to navigate having to travel miles and miles and go to another state. They don't have to navigate insurance not covering treatment. They don't have to navigate all of and traverse all of the trauma that families and children with PANS and PANDAS have to navigate. So, I hope you hear the emotion in my voice when I say that. It's uncalled for, it's inappropriate, it's inhumane, what families have to go through with these conditions. And again, in no way to compare or minimize, the plight of families going through and experiencing other conditions. But there is significant trauma that these families go through. And it has a ripple effect. It affects everyone, whether it's the misdiagnosis, the undiagnosis, the trauma from the symptoms themselves, the guilt for the impact on the whole family, at times even misguided ERP, where there may be a very well-intentioned clinician really trying to forcefully utilize a manualized treatment for these kids, where they really need a very wise-minded clinician. I use that word if folks are familiar with DBT, the clinician who trusts their instinct, who understands that it's not a one-size-fits-all, that it's really important to meet these families where they're at. There can be trauma from the medical assessments, the treatment, the blood work, the IVIG, the plasmapheresis, the financial strain on the family. And so, for sure, families can experience at the very least post-traumatic stress symptoms. Parents are mourning for their child. Their child has changed so much. Parents are doubting their own parenting. They may be unable to focus at work. They may find themselves reactive and snappy. They may feel panicky when their child shouts or make loud noises. They may have legitimate post-traumatic stress symptoms when it is flu season and it is strep season, and their child is doing well and for all intents and purposes in remission. And the thought of having them go back to school or finding out that their sibling has strep, and the panic that goes through their body, just trying to figure out like what it is that they need to do. Parents being afraid of doctor's appointments, hesitating, telling their story. Will they be turned away? Will they be told to take a wait and see approach? Low self-esteem, parents not being able to interact with others from fear of judgment, breakdowns, burnouts, frustration from being so misunderstood, low mood, self-blame. I mean, the list just goes on. These families are in tremendous need. And for the children themselves, the experience of having PANS and PANDAS and all of the sequelae can be incredibly traumatic. A sense of loss of childhood, a sense of loss of time, trauma due to feeling invalidated, like people don't understand. Even at times doubting how much control they have over the conditions, and experiencing trauma as a result of that. Trauma from doctors telling them they're just badly behaved, doctors recommending behavior charts and discipline. Discipline does not help with brain inflammation, as it turns out. Traumatic hospitalizations, whether it is medical or psychiatric, loss in friendship, and perhaps due to family members and friends not believing the diagnosis or believing their experience. Another thing that therapists can offer, and this could be a whole talk in and of itself, is the use of self-compassion. Kristen Neff is the self-compassion guru. If you go to her website, she has a ton of content. Being able to acknowledge suffering with self-compassion, acknowledging that what I'm going through is difficult, and giving oneself compassion, putting our hand to our heart, and acknowledging that what I'm going through is difficult and that suffering is a part of life, and I'm worthy of receiving self-compassion. Psychologists can offer flexibility in the treatment, as we've talked about before, and offering long-term support. This is a marathon. It is not a sprint. It is not uncommon that as kids are out of the woods with the condition, that families may still come back to process what they've experienced. Again, any flashbacks or trauma triggers that they may experience as they head out on a vacation that had been a nightmare in the past, or going back to school, or going into cold and flu season. So it's not uncommon that therapists can offer long-term support to these families, and really, establishing a plan for getting back to developmental norms, getting back to friendships, getting back to school, getting back to everyday life. And lastly, therapists can really provide hope. For many psychologists who have treated these conditions, providing hope will be an important part of the treatment plan. Just having families just having a therapist who knows what this is, who have heard about it, who knows how to navigate it, who's been down this path with families before. I can't tell you what solace, what comfort that can bring families, just knowing that they have somebody in their court who understands, who's been through it, who can help them navigate it. It just, I can't say enough about it. You're going to receive a lot of hugs, is what I'll tell you. We also provide hope in that families are exhausted, they're grieving, they're traumatized, they can feel isolated, invalidated, left out, dysregulated, financially burdened, split, isolated. And that is definitely a beautiful place for a therapist to jump in and assist. These are certainly all things that therapists can help with. And just holding hope when they're struggling to find hope can be a very important part of the unique role. So at times when the picture seems bleak, when there are setbacks, when they've gone to, they've spent a lot of money that they maybe didn't have already, and perhaps it's really they're not seeing the progress that they want. is just being able to hold that hope for the family when they've lost sight of it, and bringing them back to it can also be a very important role that the therapist plays. So hopefully I've given you some sense as to a bit of the role that the therapist can play in this condition. Our role can be many. And I strongly encourage therapists who are interested in working with these families to do so. It can be some of the most incredibly rewarding work that you can do. Thank you.
Thank you so much, Dr. Young. I feel like we could listen to talk for 2 or 3 days on this topic. We have so many questions for therapists in trying to understand their role. I do want to say that we have a diagnostic chart that therapists can work with pediatricians or other diagnosticians to work through. And that information is in the chat, and we'll pop up a slide here on that diagnostic chart as well so that you can go through that. Okay, we have a lot of questions. So if you have additional questions, you can pop them in the chat. We'll try to get through as many as we can with Dr. Young. So I think the first one that I've seen a couple of times in the chat, I'll try to sum it up, is basically sometimes kids have such severe symptoms that they're unable to participate in CBT and need to engage in the medical intervention aspect of treatment first. Can you discuss whether that's valid or not, and the timing of when it may be appropriate to start incorporating CBT or ERP?
Yeah, I think it can be tricky, to make a decision, and I think that that the answer to that comes from the thoughtful clinician. The importance and the potency of, say, for example, exposure-based paradigms, um, is essentially twofold primarily. One is that the child may participate in CBT, say specifically exposure-based therapies, and experience some habituation. They may get used to it, right? The emotions, primarily the distress, the anxiety, may subside. The second is that we have what's called an inhibitory learning model, which is that there's potent learning that's occurring, that we have those aha moments, those moments of insights, whether it is I can tolerate the distress, that it isn't as distressing as I thought, or the distress comes down. And so I think when making decisions about when to move forward with some of those more manualized parts of the treatment, I think a lot of it depends on the readiness of the child, and whether the therapist feels that based on how they're presenting, that they are in a place where they may be able to habituate, or they may be able to have insights or potent learning. So if a child is coming in and they're incredibly dysregulated, there's a lot of behavioral discontrol, a lot of big emotions, it probably would not be the most appropriate time to start to dig into some of those particular strategies, because there needs to be, again, a certain amount of ability to shift the emotion, to habituate, and to learn. And so it may be beneficial to provide some more emotional regulation strategies at that time, or some more grounding, or distress tolerance, or mindfulness, or relaxation, or to talk with the family about utilizing some different sensory strategies to assist with that dysregulation. So the way that I think about it is, and this is a broad brushstroke, but that essentially the brain kind of comes in two compartments, if you will. And that is, we have this emotional regulation center, the amygdala and the limbic system, the part of our brain that's responsible for fight and flight. And we have this other prefrontal cortex. We have this thinking, problem solving, rationalizing part of our brain. And if the amygdala is inflamed, if it's fired up, if the child is in fight and flight, any strategies that we're trying to utilize that are in an attempt to speak to the prefrontal cortex are really going to miss the mark. And in fact, not only might they miss the mark, but they might actually add more sensory stimuli to the child that adds to the dysregulation. So that's a broad brushstroke way to think about it, that if the child is in immediate and imminent fight and flight, that you're really going to want to use strategies that decrease that fight and flight response. And then once that is simmered down sufficiently, which is a case by case, artful decision, then we may apply some of those other higher level metacognitive exposure based strategies.
I see a similar question in the chat that essentially asks if CBT ERP is the cure for PANDAS and PANS. I'll let you answer that one.
Yeah, sure. So yes, it's not the cure. It is a treatment that assists with symptom amelioration. So it improves the situation, and we do know that the brain has neuroplasticity. So certainly, we do know that various CBT strategies, behavioral interventions, can create behavior change. But it's not something that would generally cure it. It's a very holistic approach that includes medical intervention as well.
Okay, terrific. And for those of you that are interested in some of the medical intervention, you can find more on the PANDAS Physician website under our treatment chart. So you can find more information there. All right, I have a question here. How do you address executive functioning deficits that remain after treatment? So they have a family in particular where psychological testing shows the deficits, and they're trying to work with the family to accept, understand, and work with those challenges so that the child can have success.
Yeah, I'm just going to take some notes. So I mean, I think it's sort of a multifactorial plan, as is often the case. So, when we're working with these families, we again can rely on evidence-based practice to support some of the treatment decisions that we make for the specific sequelae. So if there are executive functioning difficulties, then we want to apply evidence-based practice for that. There was a slide on that, so I would, kind of refer to that. So whether it's some tutoring or visual reminders, creating habits and chaining and various behavior modification, utilizing outside resources to assist, would the child benefit from some accommodations at school, a 504, extended time, schedules and timers, and it really depends a bit on the specific executive functioning issues, what strategies may be helpful. But the piece that I would add to it, if we're talking about a PANS and PANDAS case, is again keeping in mind that the course may not be streamlined, the slope of the line may not be smooth and clean, it may be a little bit bumpy. So we're really trying to meet that child where they're at. And with all of the things that we as therapists work with, to also appreciate that in many ways we're just scratching the surface of understanding these things. And in my humble opinion, anyone who tells you otherwise is is speaking out of turn, because we really are just scratching the surface of understanding these things. I do want to reiterate what Susan just said too, is that some of the work may be in acceptance. So in general, when I'm applying strategies, just in general for so many things that I work with, again, I like to think of visuals and, ways conceptualizations, is I kind of think of things in two buckets. So one is the fix it, change it, modify it, make it better bucket. So if there are things that we can do that fix the executive functioning, that make it better, if it was a psychostimulant that was assisting with attention, for example, then by all means, let's do that. If there are timers and bells and whistles and schedules and habits and coaches and tutors and accommodations and all those kinds of things that are helpful in building those skills, then absolutely do it. But there's this other lesser appreciated bucket of strategies that tends to be a little bit more in line with sort of an Eastern way of thinking of things. And that is the bucket of acceptance and meeting people where they're at, because we find that when we don't accept what is and where we're at, and we can hold a dialectic at the same time of reaching for the stars for trying to improve, but that we suffer unnecessarily when there isn't a certain amount of acceptance for where we're at. There can be strategies like a micro as well as a macro strategy of chunking, just even executive functioning strategies like chunking for the child that the parent can also utilize. Like, we're going to work on today. Today is the day that is at hand. It is in the present moment. And we're going to do the best that we can with the day that we have. And tomorrow is tomorrow, and we'll chunk that, and we'll come back to that tomorrow. And tomorrow we'll work on tomorrow.
I think
Um,
we used every single strategy you've mentioned in our home at some point. And I really just want to say that to all of you that are clinicians here learning on the call, I thought the most important thing you said was that you offer the families hope. And I think that really is true, because obviously if you have a clinician, they can't give medical advice, right? They're not on the medical side of things, but they can give so much support to the parents. And I don't know what we would have personally done without that holding of hope and support and during that entire process. So to all of you out there, huge thank you for that. There are quite a few questions about medical treatment in the chat. So as opposed to asking those questions,
mhm.
I might pose this to you as if I were a parent coming to a clinician saying, what will I do if? And so the questions might have been, I believe my child has anorexia and Lyme disease. CBT is not helping. Where might I go next? Or they might ask, how do we help with sleep disturbances if the current medication schedule is not helping? In those cases, how might you coach clinicians to help parents find those answers in the medical field?
Yeah, so I have my Rolodex of people, that I like, and I encourage all therapists to have the Rolodex of people that they like. Oftentimes, so I tend to be a bit of an information hoarder for those that know me, and that benefits a lot of the families that I work with, where whenever I hear of a good provider or practitioner, I'm always putting that in my phone. I get some of the best resources from the families that I work with, who they liked. So I will utilize those recommendations. I may at times even reach out to a family that I've worked with before who I remember worked with a Lyme literate specialist who was amazing, and I can't remember their name. And I will make those recommendations for medical providers who are, say, Lyme literate or PANS and PANDAS friendly. And I do my best to stay in my lane without withholding information. Um, I don't know if I really answered the question about the Lyme and anorexia per se.
Yeah, but it's really the same answer every time, right? It's helping them find that correct provider, which I think is really related to another question that we have a lot, which is if you are confident, the psychologist perhaps is confident in a PANDAS PANS clinical diagnosis, this child is presenting very differently than a typical OCD child does. But the family's getting pushback from the medical provider. What advice would you give in that particular situation?
Sure. So, unfortunately, that does happen. Again, I keep a Rolodex of, in my phone contacts of PANS, PANDAS, medical practitioners, um, in all subspecialties. So whether it may be a physician who subspecializes in PANS and PANDAS, whether it's a PANS and PANDAS friendly local pediatrician, really recommending I do my best to point families in the direction where I'm most going to set them up for success. And just in general, that would be a theme that I try to live by as a therapist, is doing my best to set people up for success. So if I do know that there is a practitioner who would be a good fit, who I know would not give them pushback, would give them answers and assist them and helping to get them started, I would strongly recommend that they reach out to that medical professional.
And I see our amazing background team has posted, if you do not have current resources for that, a list of directory for different specialties as well there in the chat. Another question that I've seen a lot in the chat here is, how do you tell the difference between traditional childhood OCD and PANDAS and PANS? And for those of you that are on a tight schedule, I do see we're right at our 1 hour mark. We do have 3 or 4 more questions that I believe Dr. Young is okay with answering here. So we'll continue just on in a few minutes. But if you do need to drop off, thank you for being with us. And there'll be more information on the recording. That I'll pass it back to you.
Sure. So it's it's definitely one of those things. If you have, I'll answer the question concretely, but it's also one of those things like when you've been in the field and you've worked with both PANS and PANDAS etiology as well as more of a, if you will, pure genetic etiology of some of the conditions. You know it when you see it. You get to. It's the beauty of subspecializing in these things, as you get to see what feel like outliers. Something's a little different. Something's presenting a little differently. But to get really pragmatic, things like the kind of onset, the timeline. So, historically, we think of a sudden onset for PANS and PANDAS, although, in my opinion, sometimes I see some variations with that. But you definitely would see a more sudden onset, a more acute onset. It's not uncommon with PANS and PANDAS that you may have families who will tell you that they remember the exact day that their child was different and was demonstrating the behaviors. They can literally remember the date and where they were and what was happening. It's kind of marked in their mind. We can see certainly differences in the causes. So when it comes to more of, and some of it depends a little bit on the specific condition, if it's more of an ARFID presentation or tics or separation anxiety or behavioral dyscontrol, urinary issues, tics, did I say that, OCD? There are certain norms within each of those particular diagnoses that may present a little bit differently, but the cause, would certainly be different. So with these non-PANS PANDAS diagnoses, the condition would not be caused by any kind of autoimmune antibodies, any kind of viral or bacterial insult. It would be just, for the most part, biological in nature, but biological in terms of genetic susceptibility. The symptoms may present a little bit differently. One of the things that I look for is if it's not pure. So if somebody comes in, say, just with OCD symptoms, for example, and they don't present with any sudden onset or any report of repeated strep or any behavioral changes or any of the other sequelae that we might see, tics, separation anxiety, urinary issues, behavioral dyscontrol, irritability, those kinds of things, I would be leaning diagnostically more toward a non-PANS PANDAS diagnosis. Whereas if they come in with a confluence of symptoms, sometimes that can be a tip-off, the severity, the sudden onset, families knowing, that this is not my child, that something has happened. And then certainly the treatment can look different. So we can really just stand by a little bit more pure CBT and maybe some psychotropic medication if it's a non-PANS PANDAS etiology versus if it is a PANS PANDAS etiology, then we really need to look at treating the underlying viral and bacterial root of it as well.
Okay, great. And if someone is actually here, say if we have a pediatrician on our team here with us this evening, and they're looking for a therapist to add to the medical team, are there any particular questions that they should advise that family to ask as they're looking for a clinician to support their care?
Yeah. I mean, first and foremost, you want to ask if they've ever heard of PANS and PANDAS. That's a pretty good start. Do they know what it is? Do they know what it looks like? They may want to ask, have you worked with families, with this condition before? You potentially could ask for the number of clients that the clinician has seen, because that can be helpful. But depending on where the pediatrician is or where the family is, there may be some families that are fortunate, they feel fortunate enough to work with a therapist who maybe has heard of PANS and PANDAS and has worked with 3 or 4 families, that unfortunately may need to be sufficient, that may be as close to an expert as they, can find. And, what I would say is for therapists, and again, I'm so happy that there are people that are here and interested in the topic, is, what I tell our staff when we're training is to not shy away from this condition simply because it has a little bit of a different etiology than some of the, the other conditions that we treat a non-PANS PANDAS diagnosis, is not to shy away from it, that we're going to stay in our lane. We're going to do what we normally do. We're going to provide evidence-based treatment. We're going to provide flexibility with infidelity and address many of the things that we covered in the slides today, but to not shy away from it. It can be some of the most incredibly rewarding work that we do, but I would want to know if the clinician has heard of it, is familiar with it, have they treated it, how many, potentially what kind of success have they had with that. I think those are all reasonable questions to ask.
Yeah, it's interesting. We go to the American Academy of Pediatrics conference every year, and really in the last few years, we've seen such a difference with every single conference we go to, with the level of interest that we have. Yeah, it's really wonderful. We had a recent conference where we had it was a psychiatric conference where we had a lot of psychiatrists come up and discuss with us their ability to prescribe medications for this. And so one of the things they were asking about and were surprised to learn is that they could actually prescribe antibiotics. And so I wonder if you do work with psychiatrists, both on the more traditional side of psychiatric drugs and then also on the antibiotic side.
Um, I don't know that yeah, that's an interesting question. I don't know that I've had psychiatrists that I've personally worked with who have prescribed antibiotics. If I have, then I'm just not aware of it. It's not something that stands out in my mind. But it is a good reminder, for me and for the physicians that I work with, that that is something that's that's possible. I guess that's a lie in a way. There are some specialists that I do refer to who, um, are physicians, and I don't know if their roots are in being a psychiatrist, who are PANS and PANDAS specialists. So, when I send clients to these specialty practices, they're there for the kit and caboodle. They're there for the whole, the lab work, the psychotropics, the antibiotics, a little bit of everything. But that's exciting to know that at these conferences, there's more interest.
More and more every day.
I love it.
Okay, I'm going to end with one last question that we have been getting more and more of recently. That was in the chat, which is, do you have any recommendations for a 20-year-old who's diagnosed late and having difficulty getting medical treatment? I know that's a tough one. Feel free to say you don't know.
Yeah, I always have an answer for something. Yeah, they're having trouble. Don't give up trying. Yeah, don't give up trying. Interestingly, sometimes one of the recommendations that I do make to families, as crazy as it may sound, is that there are some really exceptional Facebook groups. I'm in the Philadelphia area, and there's a really terrific, Philadelphia PANS and PANDAS parent group that sometimes I will recommend that people join, because parents rock. you know, they rock, and they know the best and the brightest and how to get things done and where to get things done. So, going grassroots and using your resources, can be helpful. It feels like it shouldn't be that way, in this day and age, that we should be able to send someone to a medical practitioner, but it is what it is. And I'm going to use whatever resources I have. So I have found those, social media certainly has its pros and cons. But I have found, mostly on Facebook for the groups, I've found that some of the PANS and PANDAS Facebook groups have been a really wonderful place to find a resource. So don't give up. Don't stop trying. Keep asking. Keep turning over rocks. Because there is somebody out there who will listen, and will help, and has resources.
Thank you. Thank you. There are so many thank yous in the chat for you personally, and we so appreciate you being here with us today. For those of you that are looking for CME credit, an email will be coming out about how to register for that credit tomorrow, and this will be available for the next 6 months as a CME, and then after that as a webinar. I just want to end by thanking you so much, Dr. Young, for joining us today and for being so generous in sharing your information with other clinicians and with all of those medical providers that are joining us here today. It's just so appreciated.
My pleasure. Thank you for having me.
Absolutely. We'd also like to thank Projects in Knowledge and At Point of Care for their generosity and help in setting up the CME. Please know that you'll receive your email for how to receive credits tomorrow, and we will have this recording up within a week. Thank you, everyone, for joining us, and have a wonderful night.